So the abstract I'm presenting is a subgroup analysis of the EPCORE NHL-1 trial, where optimization category for mitigating the risk of CRS, which was found to be a problem in some of the early studies. So diffuse large B-cell lymphoma patients were entered in this trial, and they were patients that were previously treated with greater than or equal to 2 lines of therapy. And the optimization recommendations for this particular cohort had the addition of dexamethasone premedication on day 1, 8, 15, and 22 of cycle 1. And prophylaxis was de-escalated after that time, depending on the patient. They also received additional fluid intake prior to each treatment. They held antihypertensives, received, in addition to that, IV fluids and the steroids. Patients, of course, were not hospitalized, and the step-up dosing was used where the first 2 doses were very small, and the first full dose was on dose 3. Patients were monitored very carefully, outpatient, but weren't necessarily hospitalized, other than recommendations for hospitalizations for their first full dose, but that was optional. And the study had 60 patients in it, typical patient characteristics. The median number of cycles so far is 2 for this cohort, so it's fairly early. About 70% are still ongoing treatment at this point in time. And really what was found was that the optimization cohort led to decreased rates and severity of cytokine release syndrome. There were actually no patients that had grade 3 cytokine release syndrome in this cohort, as compared to prior expansion cohorts where there was a small percentage that had grade 3. In addition, there was only 3 patients, or 8%, that had grade 2 cytokine release syndrome, compared to 16% in previous cohorts for CRS. So it definitely decreased the amount of patients with CRS and the severity of CRS in this patient population. Other toxicities were as expected with bispecifics. And I found that in general it was much better tolerated. Less patients had to be hospitalized. They also found that the IL-6 peak concentration after 24 hours after the first dose was less in the optimization cohort. And that really goes along with less CRS symptoms as well. The pharmacodynamics, looking at the peripheral B-cell depletion and T-cell activation, really were not very different between this cohort and prior cohorts. So the conclusion was that CRS prophylaxis with dexamethasone, hydration, and the step-up dosing really improved the rates of CRS with decreased levels of IL-6 and decreased number of patients who had CRS, and also the severity of CRS was decreased. There was really no impact on the depletion of B cells or in T-cell activation.